HSM 801, page 476. Implementing PHC. Community entry, assessment, diagnosis, plan, and action. Expected learning from PHC implementation. 1. Diagnose the health problem of a community. 2. Develop a primary health care plan for the defined community. 3. Deliver the component services of primary health care. 4. Provide essential curative care for common conditions at the level of primary health care clinic in a defined community. 5. Provide immunization services to a defined community. 6. Provide maternal health services and family planning to a defined community. 7. Provide health education to individual and community. 8. Identify and provide solutions to the problems of environmental sanitation. 9. Describe the epidemiology of local endemic diseases and provide appropriate preventive and curative services for defined community. 10. Manage, monitor, and evaluate the implementation of primary health care services for a community. 11. Implement appropriate training programs for health personnel and members of the community for delivery of primary health care services. PHC teams. PHC team. A primary health care team is an independent group of general medical practitioners, secretaries and/or receptionists, health visitors, community health workers, nurses, and midwives who share a common purpose and responsibility, each member clearly understanding his or her function and those of other members, so that all pool skills and knowledge to provide an effective primary health care service. Harding Committee, 1981. Typical members of a healthcare team are doctor and a registered nurse, public health nurse, sometimes physical therapists, occupational therapists, and social workers may be part of the team. Multifunctional teams are involved with primary health care. Multifunctional teams in primary health care: clinic, school, occupational health, GP office, home care ward, the core team. So each of these places has different people there. Clinics, you have general practice doctor, GP. You can look at it further, page 480. Registered nurse, MWP, GQ, SQ, CHO, receptionist records. So each one has, but for the core team, you have GP, PHN, that's primary healthcare nurse, receptionist records, registered nurse / auxiliary nurse. Situational analysis, situation and community entry, assessment, analysis, and diagnosis. Definition: community is a cluster of people with at least one common characteristics, geographic location, occupation, ethnicity, housing condition. A group of people with a common characteristics or interests living together within a larger society. The social units showing commonalities which could include place, norms, religion, values, customs, or identity. A community is a whole entity that functions because of the interdependence of its parts or subsystems. Its subsystems plus their community core are identified. Community core: 1. History. 2. Social demographic characteristics. 3. Vital statistics. 4. Values / beliefs / religions. 8 subsystems: 1. Physical environment. 2. Education. 3. Safety and transportation. 4. Politics and government. 5. Health and social services. 6. Communication. 7. Economics. And 8. Recreation. Community entry. Process of initiating, nurturing, and sustaining a desirable relationship with the purpose of securing and sustaining the community's interest in all aspects of a project or program. Refers to the process, principles, and techniques of community mobilization and participation. Involves recognizing the community, its leadership, and people, and adopting the most appropriate process in meeting, interacting, and working with them. Advantages of community entry: helps to understand the culture of the people and observe their protocols. 2. Exchange of ideas on the intended projects. 3. Supports project formulation and validation. 4. Facilitates community participation and support for the project. 5. Enhance project implementation. Steps in community entry: 1. Identify, collect information and map out community. 2. Conduct a stakeholder analysis. 3. Interactive section with key stakeholders and gatekeepers. 4. Set up cross-functional teams for project planning, implementation, and evaluation. Competencies required for community entry. Skills: 1. Maintain good eye contact. 2. Listen to both sides of an issue. 3. Prompts and probes. 4. Paraphrase. 5. Show interest. 6. Be empathetic. 7. Encourage others to listen. Attitude: 1. Punctuality. 2. Patience. 3. Tolerance. 4. Respect for other people. 5. Good listening attitude. 6. Humility. Process: 1. Identify the community. 2. Gather information about the community through formal and informal means. 3. Identify the leadership gatekeepers of the community. A gatekeeper is anyone who works to allow refuse, limit, redirect, support, or hinder initiatives in a community. They understand the culture and political environment in the community. 4. Identify a contact person and plan reconnaissance visits if possible. 5. Meet the paramount leader first and explain your mission. Then meet with the entire council and opinion leaders. Opinion leaders are individuals whose opinion in a specific matter is respected. It includes the CDC chair, that is Community Development Council chair, women leader, youth leader, religious leaders. Number 6. Present token as required by local custom. 7. Agree on plan and formation of a cross-functional team, including community members. Community entry in Bogo Kana local government area. That's the picture. Community assessment. A community assessment is an exercise of gathering information on the current strengths, concerns, and conditions of children, families, and community. Information comes from many sources, especially parents and family members. It's elicited by many techniques, including interviews, focus groups, and scanning demographic data collected by local agencies. Usually involve many types of partners, such as 1. Strategic partners, 2. Program staff, 3. Administrators, 4. Teachers, 5. Parents, and 6. Other community members. Community assessments focus on local assets, resources, and activities, as well as gaps, barriers, or emerging needs. If done properly, the resulting information is broad, accurate, and useful. Community analysis. Community analysis is the process of examining data to define needs, strengths, barriers, opportunities, readiness, and resources. The product of analysis is the community profile. Analysis can be done in the following aspects: 1. Demographic, 2. Environmental, 3. Socio-economic, 4. Health resources and services, 5. Health policies, 6. Study of target groups, 7. Other essential subsystems. Under that, you have 1. Safety, 2. Transportation, 3. Politics, 4. Community governance, 5. Communication, 6. Recreation, 7. Culture, including health and illness behaviors, etc. Definition: community diagnosis. Community diagnosis generally refers to the identification and quantification of health problems in a community in terms of mortality and morbidity rates and ratios, and identification of their correlates for the purpose of defining those at risk or those in need of health care. Community diagnosis community assessment is the foundation for improving and promoting the health of community members. The role of community assessment is to identify factors that affect the health of a population and determine the availability of resources within the community to adequately address these factors. Community diagnosis generally refers to the identification and quantification of health problems in a community in terms of mortality and morbidity rates and ratios, and identification of their correlates for the purpose of defining those at risk or those in need of health care. A means of examining aggregate and social statistics in addition to the knowledge of the local situation in order to determine the health needs of the community. Objectives of community diagnosis. The objective of community diagnosis is to 1. Analyze the health status of the community. 2. Evaluate the health resources, services, and systems of care within the community. 3. Assess attitudes towards community health services and issues. 4. Identify priorities, establish goals, and determine courses of action to improve the health status of the community. 5. Establish an epidemiologic baseline for measuring improvements over time. Three distinct interconnected levels of community diagnosis. 1. Descriptive. 2. Analytic. 3. Action programs. Descriptive, under that you have 1. Community profile, 2. Health profile, 3. Health risk profile, 4. Health services profile. Under analytic, you have 1. Demographic, 2. Environmental, 3. Socioeconomic, 4. Health resources and services, 5. Health policies, 6. Study of target groups. Under action programs, you have community health action. Clinical medicine versus community health programs. So you're contrasting clinical medicine and community health programs. 1. Objective: clinical medicine cure patient of disease. Community health programs improve health status of community. 2. Information required: clinical medicine, clinical history, physical examination. Community health programs: population data, health problems, disease patterns, availability of health services, laboratory investigation. Number 3. Diagnosis: clinical medicine, differential diagnosis and probable diagnosis. Community health programs: community diagnosis and priorities for action. Number 4. Action: clinical medicine, treatment and rehabilitation. Community health programs, community health programs. 5. Follow-up and assessment: clinical medicine, follow-up and assessment. community health programs, evaluation of changes in health status. Data collection for community diagnosis. Use of community health indicators. Indicators of health are variables used for the assessment of community health. The characteristics of these indicators are that they, one, should be valid. That is, they should actually measure what they're supposed to measure. Two, should be reliable and objective. That is, the answer should be the same if measured by different people in similar circumstances. Three, should be sensitive. That is, they should be sensitive to changes in the situation concerned. Four, should be specific. That is, they should reflect changes only in the situation concerned. Five, should be feasible. That is, they should have the ability to obtain data needed. And six, should be relevant. That is, they should contribute to the understanding of the phenomenon of interest. Demographics / socioeconomic information. 1. Population by age, population by sex, age group in bracket, life cycle cohort. 2. Types of housing. 3. Sources of power, light, fuel, etc. 4. Cultural settings, marriage pattern, bracket, polygamy, polyandry, monogamy, etc. Survivor, bracket, health services. Types of health services, bracket, PHC, SHC, etc. in the community. 2. Adequacy of personnel, bracket, quality and quantity. 3. Adequacy of other health resources, bracket, drugs, equipment, etc. 4. Referral services, bracket, mode and timelines. 5. Informal health services, bracket, traditional healers, FBO, TBAs, etc. 6. Quality, access and affordability. Home survivor, bracket, health practices. 1. Immunization records, in brackets, completion and timeliness. 2. Home diagnosis / treatment of common illnesses. 3. Recognition of signs and timelines of referral. 4. Role of fathers in the management of childhood illnesses at home. 5. Role of fathers in the management of maternal illnesses. Threats to survivor, bracket, prevalence of disease. 1. Types of diseases by age cohort and sex, bracket, infant, preschool, school children, mothers, etc. 2. Seasonal variation in disease prevalence. 3. Community perception of various diseases. Survivor / development, bracket, nutrition. 1. Basic practical anthropometry for children, age in months, heights / length in meters, weight in kg, MUAC, that's mid upper arm circumference in cm. 2. Basic practical anthropometry for adults, that is sex, weight in kg, height in meters, waist circumference, hip circumference, WHR, that's waist to hip ratio. 3. Data handling, bracket, recording, charting, classifying PM by types, that is protein, energy, malnutrition by types. 4. Identifying appropriate actions. 5. Basic presentations and signs of 1. VAD, bracket, night blindness and ocular lesions. 2. IDD, bracket, goiter, cretinism and household utilization of iodized salts. 3. IDA, that is iron deficiency anemia, bracket, tiredness, pale conjunctiva, spoon-shaped nails. Okay, so basic presentations and signs of 1. VAD. VAD is vitamin A deficiency, bracket, night blindness and ocular lesions. IDD is iodine deficiency disorder, IDD, bracket, goiter, cretinism and household utilization of iodized salts. 3. IDA, that is iron deficiency anemia, bracket, tiredness, pale conjunctiva, spoon-shaped nails. Testing for iodization level of household salts using salt test kits. Survivor / development, bracket, nutrition. 1. You have food poverty assessment. Under food poverty assessment, you have 1. Types of staples and seasonal variation. 2. Mode of food procurement and storage. 3. Household expenditure on food. 4. Family size, bracket, number of persons fed from the same pot. Then secondly, after food poverty assessment, you have infants / young child feeding practices. Under that, you have 1. Breastfeeding and breastfeeding practices. 2. Complementary feeding practices, bracket, time and adequacy. 3. Child care practices to support to mothers. Survivor / development, bracket, water and sanitation. You have sources of water, waste disposal, hygiene practices. Under sources of water, you have 1. Sources by types and populations served. 2. Seasonal variations. 3. Prevalence of water-related diseases, bracket, cholera, scabies, etc. Under waste disposal, you have household / community facilities / method of human and animal waste disposal. Under hygiene practices, you have 1. Household and personal hygiene practices. 2. Community / environmental hygiene practices. 3. Food preparation / hygiene and food handling practices. Development rights, bracket, education. Under that, you have 1. Early child care facilities / practices for stimulation at home and the community. 2. Pre-primary and preschool facilities. 3. Community participation in school management (PTA). 4. Non-formal educational opportunities and facilities. 5. Enrollment patterns (sex and completion rate of basic education first 9 years of formal schooling. Protection / participation, gender equality. 1. Household and community workload distribution (assignment of tasks by sex and age). 2. Food share (priorities, portions versus sex). 3. Decision-making organs (ratio of women to men in each organ, e.g. village development community. I guess it should be committee. 4. Women participation in decision-making at home and in the community. 5. Inheritance and disinheritance practices affecting women, children, properties. 6. Opportunities available to males, especially first sons. Harmful traditional practices (HTPs). 1. Harmful delivery practices (HDPs), e.g. hot water baths / with salt. 2. Harmful food / feeding practices, e.g. food taboos, etc. 3. Harmful widowhood practices. 4. Female genital mutilation (FGM), etc. Action Plan PHC implementation strategies. A. Traditional step-by-step guide to implementation of PHC. You have a baseline survey whereby major health problems of the community are identified. Then, situation analysis takes into consideration the existing health facilities in the area, their distribution, the health personnel available, and the availability of basic infrastructures that affect health, e.g. roads, electricity, water supply, school, etc. Then, 3. Now you have zoning of local government into districts and assigning health teams to each zone or district. Then finally, you have 4. You have registration of households, that is household numbering, and placement of home-based records in each house. Continues. So 5. Community mobilization, which includes formation of village and district health committees. 6. Training, including retraining, reorientation of existing health workers and training of volunteer health workers or village health workers. 7. Upgrading the existing health facilities to perform comprehensive primary healthcare functions. 8. Monitoring and evaluation of activities at home, clinic, community and local government levels, e.g. immunization coverage, family planning acceptance, antenatal visits versus health center, and hospital deliveries, use of ORT and growth monitoring charts for children under 5 years. B. Community-oriented primary care (COPC). Under that, you have community-oriented primary care (COPC). This adopts a population-based approach that combines clinical care with public health to carry out a systematic identification of the major health problems of the population served. COPC offers the possibility of addressing the environmental and social causes of poor health within a community. The COPC process requires 4 steps which do not necessarily need to occur sequentially. They are: 1. Defining and characterizing the community. 2. Identifying and prioritizing community health problems. 3. Developing and implementing community-specific and approved emphasis programs. And 4. Monitoring the impact of interventions. Outcome: community-oriented primary healthcare. Key features of this community-oriented primary care approach include: 1. A well-defined population or communities. 2. The use of epidemiology to assess the health needs of the population. 3. Good collaboration with the community to identify priorities and resources and plan activities. 4. Health service intervention that integrates curative, rehabilitative, preventive, and promotive care. 5. Multidisciplinary cooperation to plan and carry out the required intervention. 6. Use of effective health information systems. 7. Existence of well-motivated health teams and good management support. 8. Regular assessments of the outcome of the program. COPC continues. The community-oriented primary care (COPC) is an approach to tackling the health problems of a defined community that departs from traditional primary care practice to incorporate population-based and epidemiological data. It marries the best of primary care with the best of public health so that the primary care practitioner takes responsibility for the care of an identified community. Rather than waiting for the patient to come to the physician or practice brings care to the patient. The COPC can be an effective and appropriate model to better manage target communities, especially with regard to health promotion and prevention. It offers a strategy to market prevention, to maximize resources of a given practice and provide an intellectual base for a primary care practice to go beyond the individual and the disease. Staging criteria for COPC functions. Stage description. Stage 0. No effort has been made to define or characterize a community beyond the active uses of the practice. Stage 1. There is no enumeration of people who constitute the community. The community is characterized by extrapolation from large area census data. Stage 2. There is no enumeration of the community, but it is characterized through the use of secondary data that corresponds closely to the community for which the practice has accepted responsibility. Stage 3. The community can be characterized through the use of a database that includes all members of the community and often contains information to describe its demography and socioeconomic status. Often, such a data system is constructed over time from the active users of services, but approximately the community closely, that is, at or above 90% coverage of the community. Stage 4. Systematic efforts are made to assure a current and complete enumeration of all the individuals in the community, including pertinent demographic and socioeconomic data. For each person, information exists that facilitates targeted outreach, that is, address, telephone number, etc. Community Health Assessment Model. A CHA, that's Community Health Assessment, is a systematic process by involving the community to identify and analyze community health needs and assets, prioritize those needs, and then implement a plan to address significant unmet needs. Step 1. Reflect and strategize. Step 2. Identify and engage stakeholders. Step 3. Define the community. Step 4. Collect and analyze data. Step 5. Prioritize community health issues. Step 6. Document and communicate results. Step 7. Plan implementation strategies. Step 8. Implement strategies. Step 9. Evaluate progress. Community Health Assessment, CHA. So community engagement. Step 1. Reflect and strategize. Step 2. Identify and engage stakeholders. Step 3. Define the community. Step 4. Collect and analyze data. Step 5. Prioritize community health issues. Step 6. Document and communicate results. Step 7. Plan implementation strategy. Step 8. Implement strategy. Step 9. Evaluate progress. This is page 515. Triple A bracket model, assessment, analysis, action. Conceptual framework / triple A. Conceptualizing problems in the local perspectives, bracket, emphasizing the importance of community participation in the process. Application of the CF conceptual framework to all the sectors, bracket, rights, issues / problems. 3. Identifying resources in the community by the community for utilization for problem solving. 4. Application of the triple A bracket assessment, analysis, action process to all the sectoral bracket rights, issues / problems on a continuous basis. Care initiative. Adapting the care initiative concept to assess the adequacy and capacity for care for mothers and children at the household and community levels. Developing a community health action plan. Step 1. Identify risk factors. Scientifically established factors that are related to the health problem. May involve lifestyle, bracket, sedentary, dietary habits, environment, bracket, poor housing, unsafe water, or health system, bracket, lack of primary care. A risk factor may be related to more than one problem, and efforts should be made to think through the complete sequence of interacting factors. Developing a community health action plan. Step 2. Develop interventions and prevention activities. An intervention is a process or action intended to address an existing or potential community health problems. For each intervention, identify the process or action by which the problem will be targeted. To achieve this, you must 1. State the activity, bracket, what will be done. 2. Define the responsibility of individuals and organizations, bracket, who will do what. 3. Discuss the goal, bracket, how will this be done and when. And 4. Resources needed, bracket, amount, availability, need to source, from where. For each problem, list prevention activities that are known to prevent the health problem from occurring and interventions that have been successful in preventing disease. Developing a community health action plan. Levels of prevention. Primordial prevention focuses on preventing establishment of risk factors. Primary prevention focuses on preventing disease before it occurs or is diagnosed. Secondary prevention deals with early detection and prompt treatment of an existing problem. Tertiary prevention focuses on limiting further negative consequences of a health problem. Levels of intervention. Individual-based interventions focus on creating changes in individuals, either one at a time or in small groups. Community-based interventions focus on creating change in populations and measured by how much of the community has received some service. System-based interventions focus on creating change in organizations, policies, laws, and structures. Okay, step 3, evaluate community resources. Document all community health resources or assets such as institutions, organizations, and persons who may play a role in targeting the health problem. Step 4, draw up the operational need for the intervention such as planning, space, computer and communication skills, refreshment, etc. Step 5, examine whether intervention passes the PEARL test, PEARL, P-E-A-R-L, P, proper and politically feasible, E, economic, A, acceptable, R, resources, L, legal. So under P, proper and politically feasible, is the intervention suitable? Is any special authority or permission required? Economic, E, does it make economic sense to address the problem with the intervention? Are there economic consequences if the intervention is not carried out? A, acceptable, will the community accept this intervention? Is it consistent with local norms and values? Resources, R, are there local resources or expertise? Can this be obtained? Is the financial support available or potentially available? L, legal, do the current laws allow this intervention? Are there mandates which may interfere? Step 6, complete the Community Health Action Plan. This will include all information generated at various steps, such as all major health problems which should have been identified and reviewed, all known factors which contribute to each problem, interventions and prevention strategies that have been developed, and the appropriate resources of the community that will be needed for the intervention. It is advisable to develop a separate community health action plan for each health issue, and those responsible for implementation of the planned intervention will develop much more detailed plan, micro planning. E, adopting the management cycle, planning, implementation, evaluation. Planning, essential for the efficient achievement of all human endeavors, most basic and precedes other management functions. Process we use to select our goals and objectives and determine how best to achieve them. There is a close relationship between the planning and evaluation, and these have been called the Siamese twins of management. Therefore, unplanned action can neither be controlled, monitored, nor evaluated. The health planning process involves the assessment of health needs and of tasks which must be accomplished in order to satisfy the identified health needs. In other words, health planning is deciding in advance what to do, who is to do it, how to do it, and when. Key questions answered during planning. Where are we now? 1. 2. Where we want to go? Where do we want to go? 3. How will we get there? 4. How will we know when we reach the end of the plan or achieve the objectives and targets? Under where are we now? This requires a situation analysis bracket, description of current situation, and identification of health and related needs and resources. Where we want to go? This requires selection of priorities based on certain criteria, the identification of objectives and targets to be met to improve the service. Next, how will we get there? These details and organizes the tasks to be carried out by whom, during what period, at what cost, using what other resources, and identifying their sources in order to reach set objectives and targets. How will we know when we reach the end of the plan or achieve the objectives and targets? This involves the development of measurable indicators for monitoring progress and evaluating results. Importance of planning. 1. Avoid waste of resources. 2. To overcome future uncertainties by not leaving health entirely to chance. 3. It identifies health needs of the people. 4. By setting objectives, it establishes standards for evaluation and control. 5. Planning bridges the gap between the present health situation, that is where we are, and the desired health situation, that is where we want to be about health. 6. It determines the alternative strategies to achieve objectives. 7. It ensures that the most cost-effective and cost-efficient healthcare services are pre-selected and thus rationalizes the use of scarce resources. Planning cycle. So look at it, page 5 to 7. Cybernetic cycle. Cybernetic is self-regulation based on feedback information to identify gaps and institute correction. Okay, so you have organizing for planning, you have situation analysis, ranging priorities, setting objectives, specification of technical intervention, constraint analysis and specification of strategies, selection of strategies, detailed programming and resource specification, implementation, and finally, evaluation. Organization for planning. Set up team made up of people with knowledge of planning, community where intervention will be carried out. power and authority to ensure decisions taken will be implemented, e.g. Ward Development Committee, project initiation, stakeholders mapping, development of project charter. Situational analysis, where are we now? Description of current situation of things. It determines the most common health and health-related problems and the population groups which they affect, the factors which contribute to their development, and identifies obstacles and constraints to the improvement of health care. The situation analysis requires definition of common health problems in quantified terms, e.g. incidence or prevalence rates. Descriptive information are collected on demography, socio-economic situation, geographic situation, epidemiological situation, health resource situation. Identification of priority health programs. Most used criteria are these that evaluate programs according to 1. Their magnitude in terms of the proportion of general population or of specific subgroups of the population, such as women, children, the elderly affected. 2. Severity/danger to the individual and the community. How serious is the condition? Does it threaten life, cause major suffering, reduce productivity? 3. Amenability to intervention. 4. The cost of intervention. The 4 criteria may or may not be treated equally. Example of prioritizing identified problems. So you have problems to be tackled, you have magnitude of a problem, severity or danger, amenability to intervention, then cost. Then you have total. These are the criteria and their scores, the 4 criteria. Then on another column you have total score. Then on another column ranking. Problem 1, problem 2, problem 3, problem 4, problem 5. Scored from 1 to 4 with reversal in amenability and cost scoring. That is instead of okay. So the higher the total score of a person, taking into consideration the various scores of all criteria as they relate to a problem, the higher the priority attached to the problems. Specification of desired objectives, where we want to go. Having identified the priority health needs, the goals and objectives will be determined, targets will be set, and indicators will be established for each. Goals. They are large direction setting, wants or needs. They are concerned with the desired state of being, which gives enough focus to provide overall direction for planning. Objectives is the intended result of a program or activity. Stating the objective is essential to provide the specific directions to a plan and to enable results to be evaluated. Objectives are usually time-bound and must satisfy certain criteria: A. Relevant; 2. Feasible; C. Observable; and D. Measurable. Specification of desired objectives, where we want to go. Targets. These are short-term objectives that may be achieved by a specific date as a step towards a long-term objective. Strategies. Tactics or techniques which will be devised or adopted and utilized to facilitate the achievement of objectives and targets. Activities. Series of tasks which will be undertaken, making use of resources that would have been earmarked to achieve these objectives and targets and within the framework of the strategies adopted. Indicators. Observable, quantifiable criteria which would be measured as part of monitoring and evaluation in order to determine the extent to which objectives and targets have been met. Specification of technical intervention. For each desired objective, alternate technical interventions required to make the prescribed impact are to be specified. The technical interventions will consist of appropriate 1. Promotive; 2. Preventive; 3. Curative; and 4. Rehabilitative services which will result in the desired changes. Constraint analysis and identification of alternative strategies for circumventing the constraints. For each technical intervention specified, the major obstacles are problems, bottlenecks, and constraining factors which are likely to impede its implementation should be identified. This could be the resources or operational deficiencies identified during the situation analysis. Selection of priority strategies. 1. Priority strategy will be selected for the program based on value and rational judgment. Economic evaluation techniques such as cost benefit and cost effectiveness analysis are also invaluable tools for this. Rational judgment are also used based on feasibility, logistical requirements, and other important findings from the situation analysis. This stage marks the end of macro planning, and subsequent stages considers the micro planning, action, operational, or implementation planning. Detailed programming and resource specification. How will we get there? here, there. This involves the translation of the active interventions and strategies through the technique of activity analysis and task analysis into specific activities and tasks to be carried out during the program or project. It will specify what exactly is to be done, by whom, where it should be done, when, and with what resources. This stage can be calculated by plotting the days for the execution and completion of each activity in a sequence on a Gantt chart. Detailed programming and resource specification continued. What needs to be done? A detailed listing is prepared of activities for each program, intervention, and initiatives. How? The activities or interventions will be carried out. The procedures to be followed for technical, administrative, or managerial actions. Who should be responsible? The people responsible for the different tasks, e.g. health workers, administrative staff, etc. When should these be done? A timetable for the schedule of activities relating to both interventions and initiatives is developed as a guide to implementation. The timetable states exactly when an activity will begin and when it would end. How much would it cost? The budget, separating the capital from recurrent expenditures as well as what is already available and what additional funds would be required to bridge the resource gap. Plotting the activities against time using management tools such as Gantt charts. This is useful for monitoring and controlling the implementation of activities by eliminating bottlenecks and duplication of efforts, determining where resources can be pooled or the most appropriate time for doing the activities. Detailed plan, macro and micro. So these are a goal, objective, target, strategy, activities, responsibility, scheduling, Q1, Q2, Q3, Q4, resources, T, A, N, then indicator. Implementation. Successful implementation requires a careful attention to implementation functions. 1. Organization. 2. Staffing. 3. Leading. 4. Controlling activities of the team. It is pertinent to note that a successful implementation also depends on adequate budgeting and funding of the program. Okay, so we'll stop here, page 540. The next slide from page 541 is the Nigerian health system.